Hi, my name is Melvin Ocaña, and I'm going to talk about central Pontine myelinolysis. Definition: central Pontine myelinolysis or osmotic demyelination syndrome is a disorder consisting of non-inflammatory demyelination involving the pons, secondary to swelling or neuronal edema in patients with severe hyponatremia undergoing rapid sodium replacement, which is considered the main pathophysiological mechanism.
Welcome to USMLEFasttrack.com. The section we're going to talk about today is from
First Aid for the USMLE Step 1, 2013 edition.
Page 419.
Central Pontine myelinolysis. What is central Pontine myelinolysis? Central Pontine myelinolysis is a condition in which there is acute paralysis, dysarthria, dysphagia, diplopia, and loss of consciousness. This is a condition that can cause locked-in syndrome, and in this there is massive axonal demyelination in the pontine white matter tracts. What is the cause of central pontine myelinolysis? The cause of central pontine myelinolysis is iatrogenic, which means it's physician-induced, and this is caused by overly rapid correction of the sodium levels. So when you correct hyponatremia, you do it very fast, then central pontine myelinolysis can happen.
For more information on this topic, click on the link in the description section below. For a full USMLE Step 1 review, be sure to check us out at USMLEFasttrack.com, where we help you review the entire first aid for the USMLE Step 1 with high quality videos and hundreds of detailed pictures for a better understanding of the material. So to learn from the best USMLE review book, be sure to check us out at USMLEFasttrack.com.
Applications in medicine. Hyponatremia causes glial cells to swell via selective aquaporin channels. Treatment of chronic hyponatremia using a hypertonic saline solutions cause brain cells deshydratations and the loss of vital electrolytes, in addition to organic osmolytes such as myoinositol, taurine, glutamine, etc. Failure to compensate for increasing plasma tonicity within cells results in osmotic stress, all that while prevents the reabsorption of organic osmolytes into the cell. Clinical manifestations. The patient has usually gone through a biphasic clinical course, initially encephalopathic or presence with seizures from hyponatremia, then recovering rapidly as normonatremia is restored, only to deteriorate several days later. The initial signs of the CPM, which reflect the second phase, include dysarthria and dysphagia and flaccid quadriparesis, which later becomes spastic, all from involvement of the basic point.
So 现在可以在家里自己刷牙、煮饭，可以啊，可以做工了吗？OK， 好，放手下来。OK， 现在你走去门那边，走去隔壁，平常走走回椅子那边。
It looks limited. This one? Keep going.
Applications in Ecuador. In Ecuador, CPM is uncommon, but most patients suffered from idiopathic hyponatremia.
This is the schema that we're familiar with. These are our three categories of hyponatremia in relationship to ADH. So no urine output with normal water intake. People that make no urine, doesn't matter what their ADH activity is. Compulsive water drinking with maximal but inadequate urine output. These patients have ADH maximally suppressed. And then normal water intake with decreased urine output. These are the patients that are ADH dependent, and this is what we're going to be talking about today. So remember, ADH shifts water from being excreted into the toilet and retains it into the body. And in these patients, that reduction in urine output means that they have more water intake than water excretion, and it causes hyponatremia. There are two physiologic stimuli for ADH release: increased serum osmolality and decreased perfusion. First, let's look at increased serum osmolality. This really is irrelevant when it comes to hyponatremia because this happens when you have increased osmolality or hypernatremia. So we don't need to worry about this when we're dealing with hyponatremia. In this case, all we're worried about is decreased perfusion from volume depletion or from hypotension. And these are what we're going to be discussing in the rest of the chapter: hyponatremia from volume depletion and hyponatremia from hypotension. Hyponatremia due to volume depletion. This volume depletion can be due to GI losses like diarrhea or vomiting, or renal losses like diuretics. The mechanism of action here is you get volume depletion, leads to release of ADH, decreases the urine output, leading to an imbalance with more water intake than water excretion. Hyponatremia due to hypotension. There are three causes here: heart failure, cirrhosis, and nephrotic syndrome. All of these cause decreased blood pressure or decreased perfusion. All of them are edematous states, and those are all represent hypervolemia. Again, the mechanism here is identical. Decreased perfusion leads to release of ADH, leads to decreased urine output, leading to an imbalance with more water intake than water excretion.
Complications. The nerve damage caused by central Pontine myelinolysis is usually long-lasting. The disorder can cause serious long-term disability, decreased ability to interact with others, permanent nervous system damage, and locked-in syndrome. Conclusions. In conclusion, CPM is a brain cell dysfunction caused by the destruction of the layer covering nerve cells in the middle of the brainstem. The principal cause is a hyponatremic, and the key to improvement is a quick diagnosis.